We're
Okay,
all set.
great. I guess we don't have the slides up, but
I'll have
Stu,
it.
do you want to introduce Dr. Parry? Unmute yourself, Stu.
Thought I was unmuted, sorry. Thanks, Dr. Parry, for coming back and see us again. You were last here in October, but things are pretty bleak. Hopefully the news is better. I think it probably is. As a brief introduction to you, Dr. Parry has been a member of the Stamford community and the Stamford Hospital for 44 years. He's the Director of Infectious Disease and Microbiology at the hospital and Professor of Clinical Medicine at Columbia University. Today, this presentation will cover topics including the current state of the pandemic and what lies ahead, the course of COVID-19 in recent months, the threat posed by variants and mutations, which I think we also heard this morning in the news. Maybe there's something we'll learn today, and the effectiveness of the administration of the vaccines. So Dr. Parry, thanks again, and the show is yours.
Yeah, thanks. My pleasure. The first slide has an error because it's not June 14th, it's June 17th. But hopefully that's the only major glitch in the presentation. Can you see the slides all right? And you hear me all right?
Yes.
Okay, great. So this is the global picture. We use the Johns Hopkins epidemiology website as sort of a good measure of what's happening day to day globally. And you can drill down on this, on these data to look at individual countries. The upper right-hand bar graph shows still a ton of activity around the world, some ups and downs, and maybe it's a little bit better in the last few weeks, but there's still a lot of COVID going on around the world. The hotspots now are in South America, South Africa, and although not shown so well here because of the large populations, the rates seem a little bit lower, but the numbers are high. India and Southeast Asia has a lot. So that's where the hotspots are at the present time. If you're traveling or if you have the opportunity now to travel, these are areas you should probably stay away from. So in the US, the New York Times has really some pretty good graphs and some pretty good data. It keeps up to date, parallels the Johns Hopkins site and gets its data from CDC and WHO. And you can see that the trends here are all very favorable in the US. These are the number of cases per day. These are hospitalizations per day. Our death rate per day is also way, way down. Great news, and there have been no deaths, I think, in the state of Connecticut for the last day or two. I heard that this morning. We're testing less because the volume of cases is less and there's less concern about disease. So our rates actually reflect the fact that we are doing some less frequent testing, and maybe where those tests, the rates will change based upon the number of tests we're doing. But all in all, the numbers look great, at least in the state of Connecticut. But there's a tremendous variation across the country. This is a very nice kind of visual from the CDC map. It's kind of a heat map of risk levels and community transmission. So you can see that Connecticut's in this sort of light yellow, very low risk area of community transmission, but that's certainly not true across the country. A tremendous variation, you know, with high rates of transmission in some communities, low rates in other communities, and intermediate rates in others. So there's no good number that represents the entire country. It's incredibly variable. But when you average it out, things are going well. Just looking a little bit more closer at Connecticut, this is data from the State Department of Health, and they track data every day. We report all our COVID cases to them, and you can see that certainly compared to last spring when we had a ton of cases, and then over November to March, we had a lot of cases. Our community rates now are very low, and our death rates are also extremely low. So great news throughout Connecticut, including Fairfield County. And just as a quick visualization, The maps that are displayed by the Department of Health show the March data being a almost completely red map, and the current map having no red on it at all. And most towns in the state of Connecticut have very, very low numbers. I keep track of the data in Stamford. The week of March 27th, which is this graph, we had 140 positive tests in Stamford. Those are cases that we record, most of them in the community. And the PCR tests were positive with a rate of almost 4%. And now, even with the decreasing number of tests we're doing, our rate is less than 1%. And we only had a total of 16 cases that we detected in Stamford last week, again, compared to 140 in March. So, everything confirms the fact that we're seeing less cases. And those cases are also in a different population. In the winter, most of our cases were in people over the age of 50. And now, in the last 3 weeks, 80% of the cases that we see that we make a diagnosis of by positive PCR tests are less than 50 years of age. So the transmission is primarily in a younger population. And that's mostly, I think, because the older folks have been immunized. And I'll show you the immunization rates by age. It's really quite dramatic. So this is the graph that's from the Department of Health showing where the cases are in recent months. It's all in the under 50-year age group, and the 70 to 80-year age group, very, very few cases because of the good immunization rates. If you look at hospital data, it's also really optimistic. And you can see this is from the Connecticut Hospital Association. These are hospital rates in Connecticut, the number of cases, and you can see how nicely we've come down. As of last week, I think this was in the 30s, and we've continued to be very low. Stamford Hospital on the 8th of June, we had only 2 inpatients. And I'm happy to report this morning, we have 0 inpatients with COVID infections, with active COVID infections. That's really an achievement. I think it just speaks to the trend that we're seeing. It's our first day of the year with 0 cases. That's not to say we don't have people who had COVID being in with complications or in with subsequent illnesses that may or may not be related to their COVID, but nobody with active acute COVID in-house at the present time on isolation. Good news. The people that are coming in, where they come in, have one thing in common. This is a nice USA Today headline. Those people being hospitalized with COVID right now overwhelmingly have not been vaccinated. If you've been vaccinated, you are very well protected against severe illness, hospitalization, ICU care, and death. Not perfect, but certainly it is a truism for that overwhelmingly is true. The other thing I'd like to just show you on this slide here, and I keep track of all of our Stamford COVID tests, and these are absolute numbers by day of positive tests. And you can see that in March of last year, we had 120 to 130 tests positive per day. And then last summer, things got better. And then in the winter, we started to have this slow increase in positive tests per day, 50 to 100 tests per day positive. And now we're back down to 1 to 2 to 3 positive tests per day, 16 positive tests for the entirety of last week. You can see the purple line here represents COVID. The green line represents influenza. And this was our influenza outbreak in the winter of 2019-20, last year. And you can see that with all the public health measures that we put in place to try to prevent COVID, the influenza line is absolutely flat. So we saw for this season, in its total, 2 cases of influenza, total. And these are the past 4 seasons of influenza cases And you can see in an average year, we see 500 to 800 cases of influenza, non-pandemic, non-epidemic years. That's our usual. And this year, we had a total of 2 cases. And you might say, well, there's something unique about influenza. But when you look at RSV, which is another respiratory virus, predominantly causes illness in kids, but also causes some illness in adults. You can see that all of the public health measures that we put in place for COVID also prevented RSV. And this is the sort of seasonal RSV numbers and flu numbers, a dramatically absent respiratory viral illness for everything except COVID. But COVID is a tougher disease. It's much more contagious, much more durable. And that's why these measures aren't always very effective for COVID. The vaccine is obviously critical for control of this pandemic. Just thought I'd touch on the current clinical management of COVID and somebody who gets sick and is in the hospital. What do we do for them? Have we made progress? The answer is we haven't made much progress in the last year. The treatments that we instituted in April of last year are the same things we're using now. We use steroids, dexamethasone or prednisone to reduce the inflammation. That helps. We don't have a good antiviral drug for patients that have active COVID infection. We use this drug called remdesivir. We have nothing new. It's not a very good drug. It maybe helps a little bit, part of sort of our multiple approach in managing these cases, but certainly not a dramatic drug. We used to use convalescent plasma as a way of giving temporary passive antibody to help people get over the acute infection. Recent studies suggest that it doesn't do anything. Earlier studies suggest that it might help a little bit. So that's basically the inpatient management, drug management of COVID. Monoclonal antibodies have been useful, but they primarily have a role for mildly ill outpatients. And they do reliably prevent hospitalization. So we've used a fair amount of monoclonal antibodies for treating people who are sick, but not sick enough to require hospitalization. It's given intravenously. We've done it in our infusion center. We've probably done between 100 and 200 patients. A few have been hospitalized, but we do think that the majority of hospitalizations in this group has been prevented by the use of monoclonal antibodies. And it's been fairly easy and well tolerated. We've done some other things in hospitalized cases. We know how to ventilate the patients better. We've learned that people can be oxygenated much better lying on their stomach, lying on their back. That's called prone ventilation. We've really instituted that vigorously. We actually have created a whole team of physical therapists who come and turn the patient upside down and right side up, rotating during the day in order to improve their oxygenation and actually prevent the need to intubate the patient, to put the patient on a ventilator by doing this. It's really quite interesting. And we've also learned how to give high flows of oxygen also to prevent intubation, because the minute you intubate a patient with COVID, you have more complications. The outcome is not good. And so everything we can do to try to prevent putting somebody on a ventilator is a good thing. The mortality for COVID patients who end up on a ventilator is something over 60%. And that really hasn't changed in the last year. So we have an algorithm which we follow. It's got all these elements that I just mentioned. It's in a structured process, so everybody gets managed in the same way. But as I indicated, these elements of our protocol are small increments. The goal is obviously to prevent infection by vaccinating the entire population as best we can. So a lot of vaccines and a lot of interest worldwide in vaccinating. The first slide, the Johns Hopkins slide, shows that we've delivered over almost 2.5 billion doses of vaccine around the world. An incredible feat in 6 months since these vaccines were first developed. The two major vaccines in this country are the mRNA vaccines, Pfizer and Moderna. The AstraZeneca vaccine is still hanging out in the wings, not yet approved or authorized, I should say. the J&J vaccine also authorized in this country, and Novavax has applied for authorization. It's a different kind of vaccine. The mRNA vaccines, clearly the bulk of immunizations in this country. mRNA vaccines work, interestingly, by sort of relatively novel technology, although it's not brand new. You actually deliver mRNA, which codes for spike protein, and the cell takes up that mRNA. The mRNA is translated within the cell to produce spike protein. That protein is then expressed on the surface of the cell. We recognize that as a foreign protein. We make antibody to that protein, and that's how the vaccine works. The adenovirus vaccines work by putting mRNA in an adenovirus. That's taken up by the cell. The DNA of the adenovirus gets into the nucleus. The nucleus makes mRNA, which then produces spike protein, which is expressed on the surface of the cell. We recognize that as a foreign protein and make antibody to it. So mRNA comes into the picture whether you get pure mRNA in a vaccine or create mRNA in response to the signal from the adenovirus vector. You're getting mRNA one way or the other. The cleaner approach, obviously, is the mRNA vaccines. The adenovirus vaccines give you adenovirus not replicating, but adenovirus plus the mRNA of the coronavirus. But that's basically how they work. And the three vaccines I've put on this slide here just to compare them head to head, if you will. Certainly the trials we acknowledge were not done head to head, so these data are not totally comparable. But you can see that the clinical trials before authorization were pretty robust, 40,000 patients in each trial, really much more than we generally see in a vaccine trial. Pretty equivalent populations in terms of sex distribution, the presence of minorities, other illnesses, median age, and percentage of US versus cases that were accumulated abroad. And all of them reliably prevent hospitalization, severe disease, and death from COVID. The Johnson & Johnson, or the Janssen vaccine, is a little bit less effective than the mRNA vaccines in reducing total illness. So mild illness is better prevented by Pfizer and Moderna, but they all seem to be more relatively equivalent in preventing severe illness, which I think is the bottom line. They all have the same side effect profile, injection site pain and swelling, fatigue, headache, muscle aches, and fever. The numbers are pretty much the same. Moderna may be a little higher than Pfizer, which is a little higher than the Johnson & Johnson vaccine. Serious adverse events, these same kind of symptoms, but in a serious form, enough to put you in bed for a day, make you miss a day or two of work, only around 1%. So we all predict when we give this vaccine some minor constitutional symptoms, but they're very short-lived, and the incidence of severe adverse events is very small. And these vaccines are very effective. This is the picture of the effectiveness of the Pfizer vaccine, the Moderna vaccine. As the patient is vaccinated, you can see the number of new cases of COVID is flat with the vaccine group, but continues to accumulate in the placebo group. And the benefit of the vaccine actually happens before you get your second dose. There's a reduction in disease after about day 10 in both the Pfizer vaccine and the Moderna vaccine. As you can see, these two curves separate before the second dose is given in both instances. But we feel that second dose is really, really important. One, for duration of protection, and two, because these variants are a little bit more difficult for the vaccine to provide protection against. So this second dose becomes increasingly important as variants emerge. There's some very nice studies looking at the effectiveness in closed populations, and this is a nice study from University of Texas Southwest looking at the value of COVID vaccine in a hospital population of employees, those who weren't vaccinated versus those that were partially vaccinated versus those that were fully vaccinated, you can see dramatic reductions in disease. There's absolutely no question, in whatever way you slice and dice these vaccines, that they are extraordinarily effective for prevention of COVID infection, although not 100%, but very, very effective. So overall safety, just want to touch on this because there's been a lot of discussion recently about myocarditis and the clotting problems related to Johnson & Johnson vaccine. These side effects are a risk, but they are exceedingly rare. The overall assessment, these vaccines are very safe and very effective. They've been approved, as you know now, for children over the age of 12, and there's no upper limit to administration. Anaphylaxis, which is an allergic reaction that can be immediate and severe. Certainly, we know that can occur after the mRNA vaccines, about 4 to 5 cases per million. So really rare. And most of these patients have a history of allergy to other vaccines. So when we give these vaccines, patients with that history, we would watch for a longer period of time, or maybe suggest that they defer vaccines until a different vaccine is available, not an mRNA vaccine. The clotting problems, the thrombocytopenia, the low platelet counts with blood clots in the J&J vaccine, which caused the FDA to pause us giving that vaccine, is also extremely rare, only about 7 per million in vaccinated women between the ages of 18 and 49. Outside that, if you're male or if you're over the age of 50, the risk of this problem is less than 1 in a million. So we know the population at risk, we can advise the population at risk, and we can direct them to another type of vaccine if that's a risk. But even in the high risk group, it's only 7 per million, so a very, very low risk. Myocarditis has been in the news. I'm sure you've heard about that. That's muscle inflammation. It's being seen in young adults, particularly males, who've gotten the mRNA vaccine. But it turns out that myocarditis occurs occasionally anyway, usually as a result of a viral infection. And the risk of myocarditis after COVID is actually greater than the risk after the vaccine. So the risk benefit is clear for the vaccine, even in relationship to myocarditis. And data just out of Columbia published, I think in Circulation, was in the news yesterday, and I've seen that article. And it shows that even the myocarditis that does occur is extremely mild, responds to simple anti-inflammatory drugs, and is very transient and self-limited. So not a big deal. We're aware of it. It's a risk for COVID, and it may be a very small risk in the vaccine group, about 1 in 20,000. So it certainly is not a reason to defer vaccination at this time. Now, just like variability in COVID cases across the country, there's also tremendous variability in vaccination rates. You can just look at this map, and the colors indicate the vaccination rates across the country. The darker blue, the higher rates, the lighter blue, the lower rates. And you can see that certainly the Northeast is really pretty well vaccinated compared to the South and some areas of the Midwest where vaccination rates are very low. And that sort of correlates with the rates of COVID that's happening in the community. So very heterogeneous approaches to vaccination in this country. The state of Connecticut has consistently led the country in its vaccination. And these are data released by DPH as of Monday this week. 90% of people in this state over the age of 65 have been vaccinated. Most have had 2 doses. A few have still had 1 dose, but we're 90% coverage over 65. Over 45, 80% coverage, and over 12, we're 70% coverage. 65% of the population have had at least 1 dose. That's at all ages, including, from 6 months and up. So doing really well, particularly for the over 65-year age group. Those, as you know, in April and May of last year were the group that was mostly hospitalized and accounted for most of the deaths. And the nursing home outbreaks were huge. Those no longer are occurring because of the vaccinations. There's also some disparity, we recognize this, in race and ethnicity. And this graph shows the vaccination rates by race in residents, young people. This difference diminishes as you look at older groups. But in young people between the ages of 16 and 34, it's whites and Asian Americans that are getting vaccinated. These are the curves. If you look at Hispanics and Blacks, particularly in younger groups in this state, there's a significant difficulty in getting vaccine out to them. Pretty dramatic. But as I said, as you get into older age groups, these differences diminish, and we don't see it as dramatically. In the over 65-year population, there's very little difference in vaccination rates by race and ethnicity in the state of Connecticut. In Stamford, 65% of the population has been vaccinated, and this is the vaccine picture in the state of Connecticut. As you know, at Stamford Hospital, we partnered with the city of Stamford to create a mass vaccination program using the old hospital. Fortunately, that hospital, the old building, came into great use. We used it for COVID care in April and May of last year, and we used it for our vaccination program in March, April, and May of this year. We closed Wheeler, the hospital building, and we opened up a site at the old Pitney Bowes site, Elmcroft Road, and we have been vaccinating there. So we've had 2 mass vaccination sites. We've now closed 1. In the 2 sites, we've vaccinated over 100. We've given over 140,000 vaccines. Really a tremendous achievement. I don't think we had any vision going forward that we would administer this many vaccines. We peaked at 2,500 vaccines per day between the 2 sites, which amounts to 77,000 people vaccinated in the state of Connecticut, in Stamford. Not all of them from Stamford, of course. We vaccinated people from other towns in Connecticut, and more recently in people from New York as well. But the demand has tailed off tremendously. In the last few weeks, it's been a very, very poor response to vaccination offerings at the mass vaccination site. Currently, the falling demand leads us to vaccinate only a couple hundred people at Elmcroft. That's all per day. And 95% of these are second doses. So that tells you that only 50 people a day are coming in for their first dose. We do some walk-ups, and then we have some appointments. So the Elmcroft site, we project to close by the end of July. We won't have a mass vaccination site because the interest is not there. Vaccination needs to shift to more active recruitment. And we, along with the city, Department of Health, the Community Health Center, and other organizations in the city are trying to do much more active recruitment for vaccination, knocking on doors, trying to create pop-up clinics in apartment complexes, in church settings, in shelters, going out doing bed-bound vaccinations, pop-up events for restaurant workers and other high-risk groups. Primarily catalyzed by the Department of Health, but we have tried to participate in doing that. We have a grant actually to help with community campaigns and canvassing, knocking on doors, getting people to get vaccinated. It's a tough and uphill battle because there's a lot of mistrust in the African American community. There's a lot of fatalism in the Hispanic community where vaccines are not generally looked upon as favorably. So it's an uphill battle, but it's a battle, obviously, that we need to do in the interests of controlling the pandemic. Breakthrough cases do occur with vaccines. They're not 100% effective. You probably read about the New York Yankees having a series of breakthrough cases So occasionally people who are fully vaccinated will develop mild illness. As I mentioned before, more of a problem with the Johnson & Johnson vaccine than with the mRNA vaccines. And I believe that the Yankees were vaccinated with the Johnson & Johnson vaccine because its advantage is it's a single dose. You don't need 2 doses. These breakthrough infections are usually mild. The viral load that's in secretions is very low for the most part. And these patients are not highly contagious. So that's the good news, even with the breakthroughs. We do see breakthroughs in very elderly patients. I think we had a patient hospitalized in his or her late 90s that had a significant breakthrough. We know that at that age group, the vaccine is not quite as robust. We also know that in immunosuppressed patients, like people who've had a solid organ transplant, kidney transplant, heart transplant, for example, that vaccine responses are much lower. Antibody responses in this population, maybe only half of what we would expect in a normally vaccinated, otherwise healthy population. So these are special situations where we are kind of reevaluating, do these people need a 3rd dose? That's a big question that's being asked at the moment. The state of Connecticut has looked at breakthrough cases, 240 cases, because we are reporting all those to the state. But that's only 0.1% of the fully vaccinated cases in the state. So breakthrough infections are really uncommon. And as I mentioned, most are low risk. And most interestingly, are not due to variants. The CDC has looked at breakthrough cases compared to normal cases of COVID-19, and the incidence of variants is about the same in each group. So by and large, it's not the variants that are responsible for these breakthroughs. Variants essentially are strains of virus that have mutated. And most of the variants have multiple mutations and look significantly different from the native virus that was originally described coming out of Wuhan, China. These viruses, just like influenza, are RNA viruses, and the RNA is not a very stable compound compared to DNA. It's more prone to mutation. And so that's why we see influenza virus changing as the seasons go by and as we go from year to year, which is why we need a new flu shot every year, because the virus changes. We call that antigenic shift and drift. We see the same thing here with the coronavirus, and going forward, I think this is going to be the same pattern, just like influenza. Some of these mutations are very inconsequential. They're of no importance. That's true in influenza. It's true also for coronavirus. But some of the mutations can make these viruses more contagious. They can bind to the receptor better, or they could bind less well, and that actually would diminish the contagiousness of the virus. But Darwinian evolution would favor those strains emerging that tend to be more contagious, and that's exactly what's happened with the B117 variant, which is out of the UK, and the B617 strain, which is out of India. The explosion of variants is sort of illustrated on this slide, which is a dendrogram of the genetic mutations that have evolved. The x-axis here is timeline of COVID, and the y-axis is the growth of variants, all in different colors. The takeaway really is that there's a tremendous amount of variability, and that has increased with time and transmission of coronavirus throughout the world. What I did here is just kind of summarize the variants in these sort of traditional numerical designation. The new WHO designation, which gives them a Greek letter, alpha, beta, gamma, delta, and then the geographic association. And as you know, we're trying to get away from the geographic label because just like the Spanish flu in 2018, that label hangs with the country, and And there's a degree of blame, I suppose, that is attached to that. So the variant, the 617.2, is now a Delta variant originally out of India. It turns out that this is the most transmissible variant that has emerged yet. Much more transmissible than the UK variant, the Alpha variant, which was more transmissible than the initial one. And these variants spread very rapidly. A month ago, the main strain in the United Kingdom was the 117 strain, the Alpha, and now their major strain is this one, the Delta, which is why Boris, whatever his name is, the Prime Minister of Britain, held up the opening up of Britain because the emergence of this new Delta virus. So they're on hold now, opening up the United Kingdom. And our data here shows, this is the US data from CDC, showing the relative prevalence of variants from March through June. In March, the B117 strain, the Alpha strain, accounted for a small number, but by June, it accounts for the vast majority of strains in the US. And in Connecticut, it accounted for 70% of all of the strains circulating by the end of May. The Delta strain, the India strain, was almost negligible by the beginning of May. But now in the beginning of June, CDC data shows it's almost now 20% of circulating strains. And we can anticipate that this strain will become the most important circulating strain within the next few weeks. Imperative then that high-risk people should be vaccinated, because it turns out that the vaccines work for all of these variants. Even though they may not be quite as robust, the vaccines are so good that for all of these variants, particularly the mRNA vaccines, work very, very well. The one asterisk has to do here with this beta variant, the one that came from South Africa, where the adenovirus vaccines, the AstraZeneca and the J&J vaccines, are not quite as effective as the mRNA vaccines. In fact, the AstraZeneca vaccine, the South Africans believe, is essentially ineffective against this particular strain. But this strain is not prevalent in the United States. It's been around for a few months and hasn't really taken off. It doesn't seem to be quite as contagious, which is why it only gets, a 1+ here. So that's a good thing. The one illustration of how effective these vaccines are is the Pfizer vaccine experience in Israel, where almost all of the circulating strains were the 117 strain, this more contagious variant. And as the vaccines were given and accumulated pretty rapidly in various age groups in the country, the rates of COVID dramatically fell in all of these age groups, showing that the Pfizer vaccine in this instance, but probably the same would be true for the Moderna vaccine, very effective, even in a population affected by one of these variants. So given where we are, given the fact that we now have no COVID cases at Stamford Hospital, given the fact that our positivity rate in testing is less than 1%, and the state at large is doing very, very well. The governor obviously, in his pronouncements, has opened up the state. Essentially, we've abolished most of the mask wearing, certainly outdoors and in many indoor situations, with the exception of certain circumstances. In healthcare, we are going to continue to mask in patient care areas. We are looking at taking off masks in conference rooms, perhaps in offices where everybody's vaccinated. But we still have a significant amount of unvaccinated staff. It's almost 30%, which is too high. Lots of institutions are beginning to talk about mandating vaccine in a healthcare setting, and we are looking at that now. But certainly, if everybody is vaccinated, it's pretty safe with the current case rates in the community to be unmasked in settings both indoors and outdoors. If you're fully vaccinated, CDC says, you can resume the activities that you did prior to the pandemic. And I think that's good news. And in general, I think that's certainly true, and I support that, except in healthcare settings that I'm speaking to you from at the present time. But I'm in my isolated office with nobody else in here. We are all fully vaccinated, and in our 6 or 7 person office, we don't wear a mask currently, and I think that's perfectly fine to do. The CDC has lots more prescriptive things that you can do or can't do depending on your vaccination status. Important to know that travel now is very different if you're vaccinated versus unvaccinated. And I think a prerequisite to travel, particularly international travel. And as you saw the state of the United States, the variation in case rates across the country, which are very variable, it's an imperative for everybody to be vaccinated before they travel for their own safety and for the safety of their family, particularly on the international scene, because on the international scene, these variants are emerging across the globe at various rates in different countries. And we can't predict what these variants will do going forward. Will they be more vaccine resistant? Will they be more contagious? And in fact, will they be more severe in terms of the kind of illness that they produce? So it's been a long road. It's nice to see some light at the end of the tunnel and perhaps to be at the end of the tunnel. But I don't think we collectively can let our guard down because the virus is still prevalent in the world. As it continues to be prevalent, it will continue to mutate and new variants will emerge. And we've got to get vaccinated. We've got to promote as much vaccination as we can get. And we've got to still be careful on monitoring where we're going. We've told our staff that we reserve the right to reinstitute masking rules if our infection rates go up and if our positivity rates go up, and we will continue to follow that every week. But all in all, I think we're in a good place, and hopefully the summer will be joyful and collective, and we will have a healthy season. So I'm happy to answer any questions. I hope that I was able to summarize our current status and our outlook. Thanks very much.
Thanks, Dr. Parry. That was very, very informative and obviously very, very interesting. I see we're having questions queue up here, guys. Remember, 1 question per time, and then go to the end of the line. Raise your hand with the system reaction button or participant button. I think what I'll do is just curious. I had 1 question first, Doctor. The reluctance of people to want to take, given the stats that you talked about, I'm wondering whether when the press advertises some of these small things you described as really small numbers per million, if just that scares people, just they heard 2 people, 9 people, why does the press do that? It scares people and makes them then reluctant.
Sure, it does, and I must say, headlines are the goal of the press, right? I mean, you want to have stuff that's sensational, and it's unfortunate that it's the sensationalization of these very, very uncommon events scares people, and it's very hard to counteract the headlines that you see.
Yeah,
you probably have as good an answer to the problem as I do.
Okay, thank you very much. Okay, let's start off with Lloyd.
Yes, Dr. Parry, just wondering, maybe you can look in your crystal ball. What do you think is going to happen this winter? Are we going to have a resurgence of the various types of the viruses that are coming through, the COVID virus in particular, maybe the flu also? What should we be looking at as senior citizens?
Yeah. Well, good questions, and I think everybody's kind of curious about that. And I think we have to step back enough and be rational enough to say we don't know. But we know the course of history in the last year. We certainly can and should be prepared enough to anticipate a resurgence next winter. We would hope, being optimists, that we won't see a resurgence, that we will continue to be careful, that we will continue to push the vaccine, we will continue to mask and be cautious in a healthcare setting. And we hope that we won't see a resurgence, but we have to be prepared. We have to monitor the variants from week to week and month to month. Scientists have to evaluate those variants in relationship to the quality of the vaccines that we have now. And I know that the pharmaceutical companies are prepared to create new vaccines, which in the current technological environment is not hard to do. There will always be a delay, but I think that we just need to monitor the situation and respond as quickly as we can if variants emerge which are vaccine resistant. Bottom line is we don't know, but we'll have to be prepared.
Alan Krim.
Good morning. Thank you, Doctor, for a wonderfully comprehensive presentation, which very notably includes specifics about Stamford and Connecticut, which you can't readily get from other sources. So very, very insightful. Thank you. The question that I wanted to raise was just on your mention of these influenza cases in the past few years, where the level of incidences that you noted were between 700 and 800. Are those cases that were admissions to the hospital, or what is the nature of what happened there for those patients?
Yes, those, as the COVID data, are purely positive tests.
Oh, positive tests.
Right. Obviously, some will be hospitalized because we do a lot of testing in the hospital. And so the majority of our tests, both for COVID and for influenza, would be hospital cases, emergency room cases, cases seen in our urgent care center, and cases that are referred in from physician offices.
Thank you.
So that's our catchment area. And so those are the data that I have to analyze. And they don't represent the walking community folks that never show up to get tested, obviously. And they certainly are not fully representative of the non-hospitalized community. And that's the case both for the COVID and for influenza testing.
Larry Holtzman.
Thank you, Dr. Parry, for just a sensational and comprehensive presentation. The question I have is, I find it very disconcerting that healthcare workers, including healthcare professionals, have a fairly high degree, I think you said 30%, of not being vaccinated. What reasoning are they giving you for that? Because I find that the vaccinations clinically have such a high degree of efficacy, even more so than any drug trials. Why are these people refusing to get vaccinated?
That's a very good question. It's a complex problem. We've dealt with this with influenza vaccine for years. 10 years ago, our influenza vaccination rate was 50 to 60% in our staff. Last year, it was 95% because we mandated it. And we're going to have to do the same thing with this vaccine. There's a lot of hesitancy, particularly in minorities on our staff. They are distrustful of vaccinations. They hear stories about people who got sick from the vaccine, and they generalize these stories. So it's a battle, and it's a cultural thing in part. It's some of it is not explainable to me, which is why we've resorted to mandating influenza vaccine for our staff. We accept medical exemptions and documentable religious exemptions. And as soon as these vaccines for COVID are FDA approved, I think you'll see almost all healthcare institutions mandating the COVID vaccine. Our vaccination rates are not much different than any other hospital in the country. Yeah, everybody is sort of dealing in that 70 to 80% vaccination rate in their staff, which means 20 to 30% are not yet vaccinated.
Thank you.
Steve Fisher.
Yes, sort of short of wearing a biohazard suit, any advice for someone who, though vaccinated, is on immune suppressants and basically has no immunity?
Yeah, I think that you still obviously need to be careful. You still need to be wearing a mask and doing all the things we have prescribed or advised over the last several months in the unvaccinated setting. There's good news, however, that there's some studies coming out that show that another dose of vaccine can actually generate immunity in the vast majority of people who are immunosuppressed because of illness or organ transplantation that requires immunosuppressive therapy. So I think there will be recommendations coming along shortly that will talk about a third dose in order to boost immunity in these more vulnerable situations. In the interim, you get vaccinated. Half of organ transplants generate antibodies in that setting. And then you have to continue to be careful and wear the mask and avoid situations where you're likely to be exposed. The fortunate thing is with the case rates now in the community, the at-large risk is also falling. So you're helped out by this sort of little bit of herd immunity, if you will.
Thank you.
Yeah.
Phil Schechter.
Thank you, Dr. Parry, for a marvelous presentation.
Thanks, Phil.
And giving us all this time. If a person is vaccinated and then tested, are there any, does it affect the testing, the vaccination process?
Yes. Well, it won't affect the testing for the virus, which is usually a swab, a nasal or a nasopharyngeal or an oral swab. We look for the virus by doing PCR, looking for DNA of the virus. The vaccines don't give you a positive test by PCR. There are tests looking for antibody, which can show you that you've been effectively vaccinated. And that's what we look for to see if there's signs of effective vaccination. These tests aren't 100% correlating with effective vaccination because there's cell-mediated immunity, which is a little bit different. It's hard to test for. But the standard test you have to see if you have COVID will not be influenced by the vaccine.
Thank you.
Yeah.
Brian McDermott.
Thank you very much, Dr. Parry. As you had mentioned, there's really no very effective drug for COVID. Do you have any idea what was done for Donald Trump and Ben Carson when they got COVID and were in and out of the hospital seemingly in a day or two? Was that something special that was done for them?
Yeah, well, they, I think, got monoclonal antibody and they got hydroxychloroquine and probably some other things. But, the vast majority of people with coronavirus infection recover spontaneously with mild illness. It's only a few percent that are really sick and hospitalized. We see, surprisingly, people in their 90s who don't bat an eye and have evidence of COVID infection. So it's hard to predict who's going to get sick, but the vast majority of patients have mild illness. 50% have no illness. The other group, most of them have mild illness. It's only 5 to 10% that are sick enough to be hospitalized, and only a small percentage of those that do badly. But those that do badly, there doesn't seem to be much of an intervention that we can provide to make them better. It's almost like it's kind of predetermined. And I'm sure there are some genetic features that we don't know about that would predict good outcome or bad outcome. We just don't know what those are.
Carl Shapiro.
Hi, Dr. Parry. Great presentation. Question for those who have been vaccinated. Do you anticipate there being a need for a booster either before the end of the year or early next year? What's the consensus on that at this point?
Yeah, again, I know that the pharmaceutical companies are making preparations to give boosters using the variants as their components, if you will. But I think that's still a wait and see. We know that the spike antibodies, which seem to correlate with viral neutralization, that is effectiveness of the vaccine, seem to be very stable and very durable over a period of 9 months from the vaccine. And so we think that as long as the variants remain relatively susceptible to the vaccine, a booster may not be needed, except for those that are immunosuppressed. So particularly for the healthy 50-year-old who makes great levels of antibody that will be very durable in the current situation, it looks like we would not need a booster. But if coronavirus follows the pattern of influenza virus, particularly for the very elderly and the immunosuppressed, we may well see the introduction of a booster dose.
Just following up on that question from Carl, Doctor, when do we expect whether it's a booster shot or whatever to be available from our local doctor?
That's a very good question. Not so much the booster, but even just getting vaccinated in the first place. We would love to do that, and I think that's clearly our goal. Part of the problem is that this vaccine is very unstable. Right? It requires very precise storage conditions, freezing minus 70 degrees for the Pfizer, freezing for the Moderna. They all come right now in multi-dose vials. And once you puncture that vial, the vaccine has to be used in a period of 6 hours. So it's not really the kind of vaccine that's useful in a physician office at the moment. What we want is the single dose vials, the single dose syringes that can be easily stored and managed in a physician's office. We are piloting giving the vaccine in one of our pediatric practice offices to get started, because certainly in the pediatric population, and we're looking at vaccination going down to age 2 and eventually age 6 months, those patients don't want to come to a mass vaccination clinic. They want to go to the pediatrician's office. So it makes sense to try to move that out in a pilot program in a pediatrician's office, and we are gearing up for that. It's a problem, I think, right now of just the product and its stability and its availability for physician offices. And it's so cumbersome now. Every vaccine has to be registered with the state of Connecticut. The paperwork, the electronic transmission is incredibly cumbersome. A physician office can't accomplish that.
Yeah.
But we'll get there. And that needs to be our goal. I agree with you.
It seems like that would speak to the J&J, which does not require, seems like, those temperature requirements.
Yes, it does have more forgiving temperature requirements, but on the other side, once you puncture that vial, you got to use it in 2 hours.
Oh.
So, and it's still a multi-dose vial, and it still requires, registering, reporting, and electronically submitting data on each vaccination that you give, and that takes time.
Yeah.
So it's just not like giving a flu shot and then off you go.
Yep. Thanks. Alan Krim.
In moving much closer to herd immunity across the United States, you mentioned that FDA approval is down line. I think
Yes.
would be a wonderful mechanism to enable many institutions to mandate. In other words, not only Stamford Hospital, but corporations for their workers coming back to the office and all kinds of places. So what is the prospect time-wise for that FDA approval. I mean, it is clearly a huge help in heading off COVID and its variants.
Yes, I know that Pfizer is actively seeking formal approval, and I think Moderna is the same. So that is in process. I can't predict the FDA's timetable, but it's actively being discussed. The applications are in, the discussions are ongoing, and I would hope within the next month or two
Really?
that there is formal approval, but I don't dictate the FDA's timeline at all.
Thank you.
Lloyd?
Yes, Dr. Parry, I'd like to revisit the booster shots. Now, I had Moderna vaccination. What is the compatibility between the various vaccines and the different vaccine regimes so that I would know myself if I need a booster, I know what direction to take?
Right. That's a very interesting question. And it's actually fascinating because different countries have approached vaccination very differently. As you know, the FDA and CDC have felt very strongly that you are vaccinated, and you get your second dose. And you get your second dose with the same product you got for the first dose. In the UK, there's been a lot of interest in giving one dose, waiting longer to get the second dose, and mixing them up to some extent. So you might get an AstraZeneca and then you get a Pfizer, or you get a Pfizer and then you get a Moderna. And there is some very interesting experimental data to show that mixing results in higher levels of immunity than giving the same vaccine twice. It probably has to do with slightly different structure. The immune system then gets a different signal and ends up generating better immune responses. There's also a question about the interval between doses. The Brits have given these vaccines 6 to 8 weeks apart, sometimes 12 weeks apart. And longer intervals apart actually seem to do a better job with antibody levels as well. Obviously, we only can give the vaccines as prescribed by what was determined in the clinical trials, which was 3 weeks for Pfizer, 4 weeks for Moderna. But I think that there's lots of opportunity to mix and match. We've certainly had opportunities to do that by mistake, if you will. You know, somebody can't remember the vaccine they've had, they get a Moderna, it turns out they had a Pfizer before. The CDC does allow that and says it's okay to do that. And we've done that in situations that come up on occasion, but that's certainly not our preferred approach based upon our guidance from CDC and FDA. But lots of opportunity to kind of continue to investigate that. And I think as boosters become available, that sort of diversity in approach will happen, and we will see a mixed bag of recommendations.
Doctor, I have one last question. Of a person I know who had the virus, didn't have too many symptoms, got cured, and now he says he's not taking the shots because he figures his normal resistance to the virus is there. He doesn't need a shot. Is that a valid conclusion on his end?
Well, yes and no. There is certainly persistent immunity after an infection. Mild infections, however, tend to have immunity that fades pretty quickly. Severe infections, immunity seems to be much more long-lasting. The consensus is that after a natural infection, that immunity is not as durable as after vaccine, and that at least one dose of vaccine is recommended for people who've had COVID infections, particularly if they've had a mild infection or had an asymptomatic infection. I think that recommendation will evolve and change because I don't think most of the patients who've had COVID need a full vaccination regimen. They probably just need one dose as a booster. There's some good data to show that that's all you need, and that if you get a second dose of vaccine, after you've had a natural COVID infection, that second dose is of not much value at all. So and it's in a time when we had vaccine shortages, there was good case to be made for that approach. Now we have more vaccine than we can give. We've got vaccine in the freezer that's going to expire,
Oh, wow.
which is unfortunate.
Good. I see one last question, Joe Roccanello.
Yes, great presentation, Dr. Parry. I had a quick question related to kids under the age of 12 years old. Some of us have grandkids that are in that age bracket. And of course, we're always concerned about the safety of our grandkids. What seems to be the latest information related to kids under the age of 12, some of the testing that's going on, and how kids in that age bracket can be the best way of protecting themselves against the virus?
Right, because that data has not really been released yet because those trials are still ongoing. What I hear is that the under 12 age group has very minimal side effects from the vaccine, tolerates it very well, and it's very effective. It probably mimics the 12 to 15-year-old group, and they tolerate it well. They get great antibody levels. They get great protection. And so I think the same data will come out with the younger age group. But again, that data has not yet been released. The trials are still ongoing.
Okay.
I think one person apparently has been really waving his hand, Ben Ginta. No?
Ben, if you want to talk, you have to unmute. I guess not.
Okay. Well, Doctor, thank you very much for joining us again. Hopefully you'll come back in the future and give us some update on just the general area of infectious diseases.
Yeah,
And,
happy to do that anytime.
Good. And so we really appreciate your time. And again, from the whole organization, we really appreciate your efforts here. And thank you from us, from the whole city of Stamford. We thank you.
Well, thank you for your efforts. And I have a great team behind me, and that always makes a big difference.
Good. Thanks.
Thanks.
Joe, it's yours.
Okay, thank you, Stu. Dr. Parry, thank you again for being with us. And thank your staff and everything that you guys have been doing over the last year plus. I know when I see you in the hallway or Dr. Shaw in the hallway, you guys have aged a little bit. It's truly been a toll on you.
It's a year we hope not to have to repeat.
I know.
Thanks.
So, bye, Doc. With that, guys, thank you so much for being with us today, and look forward to seeing you at our next meeting on next Thursday, which will be our last formal meeting of the year. And as always, stay well, stay safe, be careful, and enjoy the weather. And to all the dads, happy Father's Day.